All right, so we are recording now, and let me officially welcome you to Wellness Wednesdays. I am Sally Duplantier, and I am the founder of a company called Zing. My mission is to help people live their best life longer, and I do that through helping people eat better, sleep better, move more, uh, deal with stress, and also find joy in their lives. One way I deliver on my mission is basically through these Wellness Wednesday programs. So this is something that I started during shelter in place and have continued to do so because we've gotten so much interest in it. So I'm delighted today to welcome Dr. Evan Parks. And since this is about chronic pain, I'm going to begin, before the introduction, I'm just going to begin with a quick poll. So let me go ahead and ask you a question here. And your answer is anonymous, but I'm just curious in this audience, how many of you experience chronic pain? Take a few minutes to respond, and then I will show you the results. Looks like we have about 80% of you have voted. I'll wait about 20 more seconds, and then I can show you the response. All right, let me share the results here. So the majority of you do, about almost 75% here are experiencing chronic pain. And it's interesting, I'll just tell you a personal story. I'm one of those people who has chronic pain. And so part of the way I know Dr. Evans was because I was reading his column in Psychology Today. And then I read his book, and then I thought, why not just reach out to him and see if he'd like to be on Wellness Wednesdays? And I was delighted when he accepted. So let me tell you a little bit about our guest speaker. So Dr. Parks is a clinical psychologist. He has 30 years of experience in this field, and he works in pain rehabilitation at the Mary Free Bed Hospital, and that's in Michigan. So not right down the street, but Grand Rapids. He's an adjunct assistant professor at Michigan State, working in the University College of Human Medicine. I first was introduced through his blog in Psychology Today, the Pain Rehabilitation blog. And he recently wrote a book, which I've thoroughly enjoyed and gotten benefit from. And it's called Chronic Pain Rehabilitation, Active Pain Management that helps you get back to the life you love. So what we are going to do today, Dr. Parks and I, is we're going to do a little bit of an interview. A lot of it is based on the book. And then we're going to do this for about 35 minutes, and then we're going to open it up for Q&A. So you should see a Q&A button in Zoom. If you have questions as we go, post them there, and then we will take them in the last 10 minutes. All right. So I don't, you and I have chatted a little bit, Dr. Parks, but I don't even know the answer to this question. So tell us, how in the world, as a clinical psychologist, did you get into this specialty area about chronic pain rehabilitation?
Well, that's a very good question. And thank you so much, Sally, for the invitation to be a part of your program today. I'll give you a little bit of my background. It's not typical, I would say, of a lot of people who are working in my field. I spent many years living in Eastern Europe, Budapest, Hungary. It's where we raised our family for over 15 years. And before that, I was traveling to Eastern Europe, hosting seminars and talking with people who are working in NGOs and humanitarian organizations, Christian missions, and helping them deal with stress and trauma. So the background that I have that led me into pain really was based on the work that I was doing in the Middle East and Central Asia, the former Soviet states, all throughout Eastern Europe, working with people who were in crisis and in trauma. And when I began working here in Michigan, the very same approach, actually, Sally, that I use helping people in crisis and in trauma is the approach that we use here in our program at Mary Free Bed Rehabilitation Hospital, which is helping people look at their pain from a different perspective and how to calm down that nervous system.
Wow. Okay. Thank you for sharing that.
Mm-hmm.
Now, when you and I first chatted, and that was, I think, a couple of months ago, I talked with you about the fact that these webinars are frequently attended by older adults. And you mentioned, you said it's especially important for them to understand the link between our brain and chronic pain. Why is it so important, especially for older adults?
Yeah. So, one of the things that we educate people about is how chronic pain develops. We typically think that pain uh, has its origin in the peripheral nervous system. So we have our central nervous system, which is the brain and the spinal cord, and our peripheral nervous system, which runs throughout our entire body. We have 43 miles of peripheral nerves running through our body, and we mistakenly think that pain is in the peripheral nerves. Um, and so what we get from the peripheral nerve actually is information that something has changed. And it's really up to the brain and the spinal cord to figure out, well, is that change important? Is it a threat? And if the brain determines that, yes, it is a threat, then it will produce pain. Now, here's the problem. The problem is that the central nervous system can become stuck so that regardless of what is happening in our peripheral nervous system throughout our body, we can still be experiencing pain. That's what we think is needing work. And that's where we spend most of our time in our program, helping people rewire their brain.
Wow, thank you. And didn't you say something about, too, the fact that as older adults, we may experience degenerative kinds of
Yes.
disease? Say a little bit more about what happens to our
Yeah,
spinal
so
cord. Yeah.
that's a good example. So as we age, starting in our 20s, we have a constant degeneration occurring, like in our spinal column, but in other places as well. So you probably already noticed that in the age that you're in right now, you are a little bit shorter than you were
Sure.
when you were 18 years old.
Yes.
So by the time somebody is in their 50s, about 50, or rather 80% of 50-year-olds already have degenerative disc disease. Well, most people aren't experiencing pain related to that, but they might experience pain related to that if somebody takes an x-ray of their back and says, oh, you have degenerative disc disease, and then they kind of look at their back differently as if they have a bad back. And when that switch takes place, then a person feels like, well, there's maybe nothing that I can do because I have this ongoing physical condition. But the reality is the vast majority of people who have degenerative disc disease don't even know that they have it. And the older we get, the more progressive it becomes, and more people have it until you're in your 70s, and 93% of people have it. And again, the peak period in which people experience most chronic pain is in their mid 40s and early 50s. And even though the degeneration continues throughout the lifespan and increases, actually the average pain level goes down.
Thank you. Thanks. So it seems like even though I might have degenerative disc disease, unless my brain interprets it as a threat and then starts telling me it's painful, it may not be painful. Is that correct?
Well, that is correct. And so what we need to figure out is when is something worth having a pain signal for, and when is it not worth having?
Yeah.
And that sometimes takes some ferreting out to figure out.
Yeah. Now, the other thing that we talked about is, and I learned
Mhm,
more about in your book, are that there's three types of pain, and one
mhm.
can morph and become another. So tell us
Yes.
a little bit about that.
Yeah, so three types of pain. One is acute pain. So if you hit your thumb with a hammer, you are damaging some of those nerve endings, and that's called nociceptive pain. So nociceptive pain is pain that comes from a signal. Uh, we have five basic endings. We have tissue damage, mechanical pressure, like a disc, heat, inflammation, and chemical. Chemical would be like lemon juice or hand sanitizer in a cut or something like that. And those nerves tell the brain and the spinal cord that something has changed. And typically, if a person has a broken bone, a broken leg, for example, they are going to have acute pain for 6 to 12 weeks. After that, the healing should take place and the pain should be gone. Neuropathic pain has to do with the nerves themselves, the peripheral nerves themselves, not working correctly. And that can happen usually for two reasons. One is chemical damage that happens with chemotherapy, and damage that also happens because of complications of diabetes. And so when someone has neuropathic pain, most people are picturing this as like the nerves are causing pain, but actually what's happening with neuropathic pain is the nerves themselves aren't able to send a signal because they've been damaged, they're dead, and the brain interprets that information or lack of information as a possible threat. The third type of pain is called centralized pain. So that's what we're talking about when we're discussing chronic pain. So when somebody has chronic pain, we're thinking of their brain and their spinal cord being in a high alert situation so that it's constantly looking at the signals that it's getting from the peripheral nerves as a possible problem. And so I'll give you some tricky examples of this. For example, somebody can have a lot of stress in their life, and that stress can lead to muscle tension. That muscle tension, particularly in the lower back, can get interpreted by the brain as it being an acute problem, as if an injury had occurred. But if that system stays on high alert long enough, then a person will continue to have pain. But if you do a physical exam, they don't necessarily have some kind of physical damage to their lower back. They just have a back pain that is with them constantly, absent of any actual injury. So sometimes centralized pain occurs after an injury, like after a broken leg, or sometimes centralized pain occurs in the absence of any injury.
Wow, this is fascinating. And then let me just make sure I understand it. So that centralized pain, it's still real pain. It's not, is it
Yes.
imagined pain? It's still real.
Yeah. So we actually don't need to even have a limb to have pain in some area. Let's say that somebody loses a hand in an industrial accident, and they no longer have a hand, but they could very well have pain in the limb that's missing. And so we would call that phantom pain. So
Mhm.
where does the pain exist? Well, the pain exists in the only place that pain ever exists. It exists in the brain. The brain produces a sensation that something is wrong, and the brain still has a map in it of that hand, even though that hand is missing. So pain is always real, and pain exists in the brain. If we didn't have a brain, we wouldn't have pain.
Thank you. So this is a great segue then to three stories. Something I really
Mhm,
appreciated about the book as I was trying to get my head around all of this was that you told us stories about real life people. I'm sure the names were
mhm,
changed. And I found their
mhm,
stories fascinating. So for our session today, I've chosen three of them. And I thought this one about Rachel is really timely because this is how chronic stress can become chronic pain. So tell us
Right.
about Rachel.
Sure. So chronic pain in the form of fibromyalgia is a pretty common condition that is misunderstood and misdiagnosed. And that is really a part of Rachel's story. A lot of people that we see with fibromyalgia, they'll have had the symptoms for 5, 10, 15 years, and they will be told it's one thing after another, be given one medication, one type of treatment after another, and really not make any progress. And eventually, some of these people are sadly told that they have no real pain condition, that it's just all in their head. So Rachel's story was like that. And so picture a 35-year-old woman, 2 kids, working a busy job, managing her career, managing her home. And, in the progression of her adult life, late teens, she would have had maybe an injury or two in her teen years, maybe an illness, maybe some stressful situations in her life early on in her adult life, possibly a surgery. And then you have this progression of events that happen that make it hard for her to recover, make it hard for her to get back on her feet. And she becomes chronically exhausted. And then she becomes immobile in a sense. She moves less. She sits more. She lays down more. Saturdays, instead of running around with her kids, are spent in bed. And then progressively, a person in that kind of condition is going to have achiness, soreness, and then you have this added stress response that we'll get into in a little bit, I think. And the stress response produces inflammation. The inflammation occurs throughout the body to the point where she ends up with what we call widespread pain, which is diagnosed as fibromyalgia.
Oh, so you answered a question. I wasn't sure what fibromyalgia was. Say it again. Give us the definition of fibromyalgia.
Yeah, fibromyalgia is characterized by widespread pain. So you have pain in all 4 limbs, the trunk of the body. Um, there is sensitivity to the touch when there really shouldn't be. Different fabrics, different types of clothing, sheets, pajamas,
Mm.
shoes, things that shouldn't cause pain begin to cause pain. And a diagnosis is often made by a doctor finding pain points on different areas of the body, by just touching these areas and finding that there are very specific spots that are very painful. And that's how the diagnosis is made.
Wow. Okay. So I think this is especially timely because talk about a time of a chronic stress, being in the middle of a pandemic, still a
Hmm.
lot of shelter in place, for older
Hmm.
adults, the associated social isolation,
Yep.
loneliness. We can see where it could certainly lead to some type of chronic pain.
Yes.
Yeah. All right. So I found David's story very interesting, and I think this is where we might get more into the stress response. So he was a
Hmm.
young man. I think he was 26, and he had some kind of an accident. So tell us
You're right.
about David and also how improper pain management can make pain worse.
Sure. So David's story is pretty simple. Working in a factory, um, moving some heavy pieces of equipment. He feels that his back goes out. He drops to his knees and can't move. Um, excuse me. A very, very unwanted event, for somebody who's otherwise healthy and strong, and surprising. So the recommendation for David was, because of his ongoing pain, was to have surgery. And that initial surgery, didn't lead to the kind of pain relief that David was expecting or the surgeon. And so he gets a second surgery. And then from that, He's suggested to have a spinal cord stimulator, which is electrical stimulation of the spinal cord to block pain signals, which didn't work either. And so by the time he comes to a pain center like ours, a person like David is very frustrated, very discouraged, and really doesn't know what to believe anymore, because he's been told multiple times that, well, this approach will help and this will help and this surgery. And so a person like this is generally on quite a number of medications, often opioids, and they're not finding relief from that. And they feel like they're at the end. And so that's where the story really begins for David when he comes to our program.
Yeah. And then you talked a little bit about how there's this never-ending cycle of pain, especially for somebody
Yes.
like David, who's maybe exhausted some of the traditional remedies.
Right. Yeah. So this is where I'd like to get into the stress response and the immune system, which is so important for us to understand. So pain itself is something that the brain has to adjust to. And when we're adjusting, it triggers the stress response. Well, the stress response is super adaptive. If you're in a near miss car accident, somebody cuts you off on the highway, you're going to experience that stress response. But we also experience that same kind of stress response, even though it's not quite as intense, um, if we have a flare up of our pain. Now, that stress response is going to lead to one thing for sure: increased muscle tension. But it will also trigger another protective system that we have in our body called the immune response. So our immune system in a near miss car accident releases all kinds of protective things like white blood cells. These white blood cells travel throughout our body being ready to help us if we are cut or have a broken bone. Well, let's say that you're sitting at home on a couch, you have a flare up of pain, you have your stress response, and this triggers your immune system. The immune system triggers this avalanche of white blood cells and other kinds of responses that help protect us. Well, if there's nothing there that needs protecting, what's being done by the immune system can lead to inflammation, because that's part of the way that the immune system helps us. It brings about inflammation. So if you cut yourself, that white blood cell response brings inflammation to that cut area. Well, it can also bring inflammation to your muscle tissues, to your tendons, to your joints. So your joints become swollen and stiff and very hard to move. That's the immune system working against you. Once that happens, in David's case, he became exhausted from being so sore and so stiff that he could hardly move. And the less he moved, the less he could move. And that affected his sleep, which led to his mood going down, which made it even harder for him to even want to move. And the less he moved, the more his pain spread. And that's kind of the cycle right there, Sally.
Wow. And I can absolutely see how it happens. When I read about this and now hearing you talk about it, it's so logical. So
Yeah.
then I read a little bit about David's rehabilitation, and I'm going to show some graphics, and maybe you can talk us through how this idea of pacing was able to finally help him overcome what had become a very
Yeah.
low threshold to pain.
Yeah. So what you see on the graphic there are two mountains. And the mountain on the left-hand side is before David had his injury. Basically, he could go all day long up that mountain before he would even hit a discomfort zone, which is that little green area. After his injury, he barely has to move at all, and he's immediately into discomfort. And a little bit beyond that, the top of that green zone then would be the pain threshold. So poor David, he's now in this very painful spot where any kind of movement hurts. Well, most people like him are go-getters, and they have plans and they have projects and they have to get things done eventually. So what you can see here on the next slide is that David waits for a good day when his pain threshold is a little, or his pain levels are down, And then he has his long to-do list, and he says, well, I'm going to get to the yard, I'm going to work on the car, and I'm going to make sure that that bathroom sink is drained, working right. And so he goes through his checklist, and then, about 3/4 the way through the day, or maybe halfway through the day, he punches through this discomfort zone right out the top of his pain threshold. And now he went from feeling good in the morning to being in extreme pain. And then he stops all his activity, and you can see that curve drop right back down. And now he has to get out of his pain zone. And what he does is he chooses to just not do anything, for the next several days until he has a good day again. And then that good day comes again, and boom, he's back into that loop again. But this is what pacing is. Pacing is recognizing that there's a certain amount of activity that we can engage in that's uncomfortable, but not painful. So let's say that you can walk comfortably for 15 minutes without getting into your pain zone. What you would want to do if you want to practice pacing is divide that in half and walk for 7 minutes and rest for a few minutes. And then walk for 7 minutes, rest for a few minutes. By doing this, what you're doing is beginning to recondition your brain not to associate movement with discomfort, movement with pain. And as your brain begins to say, oh, this movement is actually helping me get stronger, increase my flexibility, increase my strength, increase my endurance, the brain begins to reevaluate that movement. It begins to put it out of the threat category into the safe category. Nothing really is changing mechanically with a person's body, but how the brain is interpreting that information is changing. And that's what David began to do. He felt very frustrated at the beginning trying to implement this because he felt, I should be strong. I can vacuum for more than 5 minutes. Why should I rest? Well, the point of vacuuming only for 5 minutes is that you condition yourself to be able to do it and never have that be associated with pain. And that takes a lot of discipline to do.
But it eventually retrains the brain so that I think,
It
okay,
does.
I'm moving and this is something positive and it's not a negative.
Yes.
Yeah.
Yes.
Wow. All right. So then let's talk about Nancy's story. This one was especially fascinating to me because she had migraine. I have migraine. So I was like, oh, I want to know about Nancy. And we learned a little bit about how protecting our bodies from pain can actually make it worse.
Great. Yeah, so Nancy, like many people, was in a car accident, but this car accident was 20 years ago, and she ended up with a neck injury, shoulder problems, and initially she had shoulder neck pain, but that shoulder neck pain then ended up being pretty serious headaches. The headaches eventually progressed to occasional migraines. Those occasional migraines became frequent migraines to the point where she was coming into our program with daily migraines. And so she had been to all the best places. She had been to Mayo, she had been to Cleveland Clinic, University of Michigan, that kind of thing. That's what I'm picturing about this person. And so and it's very common for people to have been to many places, but she began to learn about this concept of how does the brain decide if something should be treated as a threat. And we use this picture of a scale. You can see the scale. One side of it says evidence for safety, and the other side said evidence for danger. And if the brain collects more evidence for danger, then the brain says, yep, this needs to produce pain, or we need to produce pain to protect the person because there's lots of evidence for danger. Well, when Nancy came into our program, we asked her, how do you know that you should have kind of the chronic pain that you do? And she said the typical things. She said, well, my mother had migraines. My son's a doctor and he told me I should, take this medication. And the fact that this medication that I take for my migraines doesn't even work just proves that I have, you know, um, a really bad problem. And the doctor told me that the images of my neck are so bad. It's the worst neck that he's ever seen. It's no wonder that I have all of these problems. And my pain limits me. I can't do things. I'm losing contact with my friends and my favorite activities. And so she had lots of evidence, and we then educated her about evidence for safety. So evidence for safety is learning very simple concepts. For example, that when we're in pain, that it doesn't mean that harm is being done. So we have people memorize the phrase, pain does not equal harm. Usually we think that when we're doing something and it hurts, that damage is happening. Typically, that's not true. And she began to learn that motion is lotion. The more she moves, the better she's going to feel. That pacing is progress, so that she can rewire her brain. That images actually don't tell us everything that we need to know. And she began to collect evidence for safety. And it wasn't very long into our program before she was experiencing uh, day after day without pain.
Thank you. So I want to ask how did you finally help her? Because she's getting
Yeah,
better. And then I know there was this an incident with a big party and kind of an aha moment.
yeah,
Tell me that story.
yeah. So the aha moment for Nancy was there are things that are important to her. And she realized that if she focused all of her attention on her pain, it would block her from really engaging in what was important to her. And what she decided to do is switch that around so that she focused more on what was important to her. And she decided that she was basically going to take pain with her wherever she went. And when she did that, Sally, what really happens in her brain is her brain says, Nancy is no longer treating these migraines or headaches as a threat. Maybe they aren't. And as she began to really pursue what was important to her, her pain levels went down remarkably.
Thank you. So I think with Nancy, we talked about, is she pain free now? And you said no, but she's back to the life she loves. Just say a little bit
Yes.
more about that as the intended outcome of the program,
Yeah.
the book, because there's a distinction.
Yeah. Yeah. There sure is. There sure is. Our goal is always to help people function better. And for each person, that's going to mean something different. For one person, it might be getting back to hiking. For another person, it might be playing with their grandchildren. For another person, it might be engaging in a hobby that's really important to them. And as we engage in those things that are important to us, it doesn't mean that pain isn't going to show up, but it doesn't mean that pain has to be in control. What we want to see happen is for a person to visualize their life as them driving a car and pain is a passenger. Might be in the passenger seat, might be in the back seat, might be in the trunk, but pain is not driving the car. When people come into our program and they're stuck with chronic pain, they really see pain as being in the driver's seat of their life, and they're just a passenger needing to ask permission from pain. That's the kind of thing that we want to see changed.
Thank you. Before we open this up for general questions, I want to talk a little bit about mindfulness
Yeah,
because, I think in probably every webinar we've given, at least half of them, I've touched on mindfulness. I have to say that it's become more important to me since the start of COVID. I now have a mindfulness practice. Tell us about mindfulness and the role it plays in dealing with pain.
yeah. So mindfulness is a neat concept. So mindfulness really has to do with being able to notice something in a particular way. And that particular way is with kind of curiosity and openness. And then as we notice what is happening with us, we try not to evaluate and judge what it is that we're noticing, or change the sensations that we feel. So that becomes a training tool to help the brain recognize the kind of sensations that we have without immediately categorizing those sensations as a threat. We just notice that it's there and allow it to be there. And then we suspend this kind of dialogue that happens with the brain, where the brain says, oh, this is how long it's going to last. This is why you have it. Boy, what does this mean? Are you going to end up in worse condition? You better sit down. There's a lot of activity that's going on in the brain when we have this struggle.
Thank you. And I'm going to share this resource. And by the way, I will be sending everybody a link to the book and a link to this website, because I actually went out onto the Pain Rehab Source website, and I found these amazing mindfulness meditations. And I was having a particularly bad night, and I initially went right to 7, reducing pain. And then I thought, it's not quite like that. There is a real benefit in establishing a mindfulness practice, and it is a practice.
Mhm.
So I would encourage people who haven't done mindfulness, start at the beginning. Start noticing the body and breath, and over time work your way up to these. But
Mhm.
I just thought it was a great resource for people getting used to mindfulness. All right.
Mhm.
So we can't all come to Grand Rapids and come to your clinic. So I
Yeah.
asked you to share with us kind of 2 main pieces of advice for getting
Yes.
started in retraining our brains.
Yeah. So one of the first things that I really want to encourage you to think about if you're struggling with chronic pain is that, number one, chronic pain is persistent. We have to be persistent in tackling it. Um, I'll share techniques with people, Sally, and they'll give it a try for a few minutes and they'll say, "Oh, it didn't help." Well, it doesn't work like that. We have to be persistent. We have to uh, do things that increase our strength, increase our stability, increase our endurance, increase our flexibility, calm the mind. So I picture the exercises like you mentioned with mindfulness, like learning to play the guitar. We could watch a video on YouTube and in 10 minutes, pluck away, but we're not musicians. To be a musician, you really have to put the time in. And using a mindfulness exercise, using a breathing exercise, we have to be really persistent in doing those very simple things consistently. And secondly, is this concept of letting go. We wrestle with pain. We wrestle with all the friends of pain that show up with pain, the discouragement, the frustration, the anxiety, the depression, and we want to get rid of those things. When we try to push pain away, we are reinforcing in our brain that pain is a threat. But when we say to ourselves, you know what? I haven't been able to get rid of pain. What if I just turn toward it with willingness, allow it to be there, even though I don't necessarily um, want to learn to like it? That's really not the concept. But the less we wrestle with something, the less our brain treats it as a threat. And so I like the example of quicksand. Picture a person falling into quicksand. The more they struggle, the faster they sink, because you create a vacuum underneath yourself in this quicksand. But the only way to survive in quicksand, apparently, is to spread your arms, spread your legs, lean back into it, and allow yourself not to move. Boy, that's hard. That's hard not to struggle. But when a person does that, they float to the top. And that's the kind of process that we teach people. We teach people, Sally, how to pass kidney stones without pain.
Hmm.
You know, it is possible because the more we're afraid, the more we're anxious, the more we're upset, the more we push it away and say, this is terrible, the more we convince our brain that it needs to protect us. But when we turn towards something with willingness and we relax ourselves, we just say, it's a sensation. Thank you for telling me. It turns down the volume.
Well, thank you. I think we covered quite a bit, but I know people have questions. I'm going to stop sharing my